For the next talk, I would like to invite Colonel Pradeep. Dr. Colonel Pradeep is currently working at the most decorated Army Hospital Ophthalmic Center of Delhi, that is Research and Referral Hospital. He's going to talk about exploring wide field OCTA insight into macular telangiectasia. Over to you, Dr. Pradeep.
Good morning, everyone, and thank you so much for attending our IC. First of all, I'd like to thank AIOS and Ankur. First of all, I'd like to thank AIOS and Ankur for giving me the opportunity to present today. So, talking about wide field OCTA. Sorry. So, the two images that you see here, one on the right-hand side and one on the left-hand side, is a 8 mm and 8 mm scan compared to a 12 mm by 12 mm scan. And today we are not limited to 12 millimeter scan, we are talking about 18 millimeter scans. And in the trade section, if you had gone to the Intelite podium, they have something called Dream OCT, which is now capable of taking 24 millimeter scans too. So we have moved from wide field OCTA to ultra wide field OCTA. So the technology has made it possible. So continuing the discussion which Professor Vinod had made, so initial attempts in retinal vein occlusion imaging with OCTA were made with enhanced field imaging. So what the researchers were doing were placing another lens in front of the spectralis machine and increasing the field of focus from 6 into 6 millimeter to 8 into 8 millimeter. And based on their findings, they were able to chalk out the CNP areas in BRVOs and were thinking of advising therapies for the same. By 2020, the research had developed to an extent that we were able to identify neovascularization elsewhere in cases of BRVO and even document them as either CFN type or a nodular type as seen in these cases. But what becomes of this research? By 2022, we had started talking about monitoring the progress of patient using periarterial capillary free zone improvement. And as you see in these consecutive images, we are talking about the normalization of the periarterial flow zone and continuation or discontinuation of anti-VEGF therapy based on OCTA images. Now, based on the wide field OCTA images today, we are able to assess that in such a case where you have a central macular edema but very few CNP areas in periphery, you will give it a chance to develop collaterals and wait. While in a case like this, where even though the macula may appear normal but you have a large CNP areas in the periphery, we will not wait as was recommended long time back in the CVOS and BVS studies and go ahead and do targeted laser photocoagulation to reduce the genesis of VEGF in these cases. OCTA has also found its use in other systemic diseases, and in a case of uremia, when you see multiple cotton wool spots at the posterior pole, initially the thought process was that it was a disease limited to the posterior periphery, but now once you have a wide field OCTA image with you, you realize that the periphery appears quiet because there is no blood flowing through that area, and it is manifest only at the posterior pole because the OCTA shows exactly where the blood is flowing. Similarly, we have been identifying neovascularization elsewhere in such cases, directing our therapy to the CNP areas, and in cases of retinal vasculitis, in one such case of tubercular retinal vasculitis, where we realize that now the disease activity is progressing toward the macula, it becomes clinically a sight-threatening disease, and the immunosuppression in such cases can be escalated from routine steroids to immunosuppressants and probably biologicals like adalimumab. Now, talking about the research which has occurred in newer areas like myopes. So, as early as 2022, people started documenting retinal vein cell density in myopes. You will think that what is the usage of such a technology? Now, we have started documenting that in high myopes, to document glaucoma, you can use an OCTA. So, an RNFL defect in a myope can be better picked up
on the OCTA image compared to the red-free image as was shown in this study. And these RNFL defects, better appreciated in myopes, give us more tangibility in making a diagnosis of glaucoma and treating these patients, where looking only at the optic disc, it would have been difficult to make that diagnosis because the beta zone is not very evident. So we have found usage for OCTA also in glaucoma. Now coming to diseases like SLE, it has been possible to identify disease activity in cases of SLE where the cotton wool spots have been corroborated with deep capillary plexus flow void areas as shown in this image with the red dots, and also in finding out whether the disease has halted or is continuing with the development of new CNP areas. And if you find that in an SLE case you are having a propensity to develop new CNP areas over progressive OCTA, one can escalate the immunosuppressive treatment. There has also been research in field of CSCR where choriocapillaris flow has been studied, and we have found that in the central subfield and in the nasal subfield, when you have flow void areas in choriocapillaris, they tend to have a longer duration and active CSCR compared to normal. What these research will have an impact on the treatment of CSCR remains to be seen. Similarly, OCTA angiography has been studied in arterial occlusions where there is an inverse correlation between the retinal thickness and superficial capillary vexillary density with the final visual outcome. For research sake, OCTA was studied in cases of XLRS where they have given out these beautiful void flow areas in deep capillary plexus. They help us in finding out the staging and the progression of the disease, but again the impact on management of XLRS based on OCTA angiography remains to be seen. Now in advanced XLRS they have given these beautiful images also where they show that if the separation of the inner and the outer retinal layer has progressed towards the periphery, it can be better mapped out on an in-face image of OCT angiography. The frontiers have been reached even in uveitis, where we have been able to develop classification systems for Vogt-Koyanagi-Harada based on OCT angiography images, and presence of flow void areas in the choriocapillaris segment or the deep capillary plexus segment tend to correlate with active disease compared to a convalescent disease where the earliest sign is the disappearance of these flow void areas in the choriocapillaris segment. Now coming to the second part of my talk, that is macular telangiectasia type 2. As we all know, these are perifoveal grayish areas which appear more temporally than nasally. They have a stage progression over 10 to 15 years, and what one must learn to find out is to look for these discrete white discolorations in the temporal part of the macula to pick up the disease early. Now this is what initially was our understanding of MACTEL, that we used to look at the fundus fluorescein angiography and wait for these fine hyperfluorescences to occur in the perifoveal region. But this was a slightly late way of picking up the disease. The books talk about looking for a right angle dipping vessel, but I will share this insight that in a busy OPD, it is pretty difficult to look for such a case if you are dealing with 100 to 150 patients a day. So one should look for multimodal imaging, and autofluorescence, OCT and OCTA come to our rescue. By 2020 in MACTEL Project 8 report, they had been able to give a classification for various stages of MACTEL and the associated complications that were occurring. But by 2022, there was introduction of OCTA into the classification system, and this was the recent classification system which has been upgraded, and there has been an inclusion of OCTA characteristics, mainly firstly the splaying of vessels in the superficial capillary plexus area and presence of flow void areas in the deep capillary plexus, and the presence of telangiectasias in the perifoveal region. So this is the classical progression of the disease, where in image A, you see development of few temporal splaying areas in the deep capillary plexus, which tend to become completely perifoveal, and by the late stage you start seeing development of telangiectasias even in the superficial capillary plexus. So the deep capillary plexus changes also move together with the superficial capillary plexus changes, where in the early stages, though the DCP looks quite normal, but you see development of telangiectasias first in the DCP in image H, and then they progress to a complete disruption of the deep capillary plexus as the disease progresses with fibrosis and development of pigments. This is another example where we can see that there is a complete disruption of the deep capillary plexus as the disease progresses, and in image E you can see multiple telangiectasias present on the temporal part of this fovea. The mactile can be present with concurrent retinal disease, and that is where the importance of OCT angiography kicks in. So in case of diabetic macular edema, if you are having a concurrent macular telangiectasia, even after multiple sessions of anti-VEGF or steroids, you will still continue to find cavitation areas and may unnecessarily treat them. But if you had an access to OCT angiography and you notice a temporal splaying of vessels on SCP, or the presence of these fine telangiectatic vessels on deep capillary plexus, you can make a diagnosis of mactile 2 and stop treating this disease. Mind you, mactile 2 is more common in diabetics and it is more frequent than we usually document. Similarly, choroidal neovascularization can develop in macular telangiectasia. We have seen cases on record where a mactile has been erroneously labeled as a PCV and been treated for almost 2 years with 20 odd injection. And on the other hand, in such a case where a follow-up case of macular telangiectasia developed a CNV, was treated with anti-VEGFs and the disease remained stable for about 2.5 years as reported. Also, if you have a full thickness macular hole with degenerative changes, one should do an OCT angiography to document that this is a neurodegenerative disease and the patient will have a poorer outcome after surgery. There can be other masqueraders with mactile, if I may continue for a minute or so. So there can be one with multiple PEDs, and when you do fluorescein angiography or ICGA, the fluorescence from your PEDs will overlie the presence of these fine perifoveal leaks. But in an OCT angiography image, it will be more easy to pick up the presence of concurrent macular telangiectasia. So one has to be on a lookout for this disease in macula, only then your skill in picking up mactile will increase. Similarly, we reported this case of central serous chorioretinopathy and macular telangiectasia. And skipping to the important part, I will show you one of our follow-ups, how we are following up cases of mactile on OCTA and how it changes our management. So this lady presented to us as early in 2022, had changes of mactile clinically. We started recording the OCT angiography and were managing this case. In 2023, late 2023, we started noticing 2 hyperreflective signals in the deep capillary plexus and couple of hyperreflective signals in the avascular zone. We still did not believe that the patient had a development of MNV, though the patient did complain of increasing metamorphopsia. 3 months after that, you are able to pick up these high hyperreflective signals in the avascular zone, metamorphopsia is increased, and these patients do respond to anti-VEGF therapy. So I will conclude that keep hunting for macular telangiectasias in your OCT angiography images. It will save you a lot of pain in post-operative cases of cataract, in cases of DME when you are treating a concurrent mactile, and in cases of CSC where a mactile might be hidden. Thank you so much.
Thank you, Dr. Pradeep, for the excellent talk. and excellent cases that you had shown.